The last case is from AIIMS Hrishikesh. You start presenting your case.
Yes, sir. Mr. Rahul Singh, 30-year-old male, Hindu by religion, resident of Muradabad, UP, farmer by occupation, studied up till 5th standard, married, history given by patient himself and seems to be reliable. Presented with the chief complaint of chest pain since 1.5 months, dyspnea on exertion since 1.5 months, and palpitations on exertion since last 1 month. Patient was in best of his health 1.5 months back. While doing farming activity, cutting sugarcane in his farm, he experienced sudden onset, severe retrosternal chest pain, stabbing in nature, radiating to back interscapular region, not relieved by rest, and lasted for an hour. His pain spontaneously reduced and became episodic to mild pin pricking type till he presented to us, and it was not aggravated with exertion. Pain was not associated with diaphoresis, no episode of any loss of consciousness or perspiration. There was no preceding history of vomiting, retching, or chest trauma before the pain. Pain was also associated with difficulty in breathing, which was sudden onset, which led the patient to discontinue his work. The dyspnea was even present when patient took rest. Patient found difficulty in lying down and was more comfortable in sitting position. Patient consulted locally for the same and took some herbal medications and stayed at home for a week. Patient confined to himself to the bed, and his chest pain and dyspnea improved, and patient was comfortably lying down and doing routine household activities for a week. 1 week later, he resumed his activity in the farm. However, he was getting breathless while walking to his farm, which he used to walk without discomfort before this event, suggestive of NYHA class 2 dyspnea. He used to take rest and then used to resume his activity. However, since past 10 days, his breathlessness has increased to such an extent that he gets breathless even on his routine activity like going to washroom or bathing, suggestive of NYHA class 3 dyspnea. This breathlessness was associated with difficulty in lying down, and he had to use 2 pillow supports to make himself comfortable in night. There was no associated history of paroxysmal nocturnal dyspnea, no history of cough, wheezing, or hemoptysis, no history of weight gain, no pedal edema, no increase in abdominal girth. Along with dyspnea, he also complains of palpitations on exertion for last 1 month, which was insidious in onset and occurred only on exertion and relieved by taking rest. And the palpitations were not associated with dizziness or any loss of consciousness, and also not associated with post-palpitation diuresis. In negative history, there was no history of fever with chills or abdominal pain, no history of any limb swelling, no history of oral or genital ulcer, joint pain, or hair loss, no history of headache, confusion, delirium, or weakness of any limb, no history of decreased urine output, no history of tuberculosis, and no history of any sexually transmitted disease. In the past history, there was no history of hypertension, diabetes mellitus, no history of any systemic illness in the past, and no history of prior admission to hospital. Personal history: he is married with and father of 2 children, vegetarian by diet, having altered sleep and appetite for last 1.5 months, normal bowel and bladder habit, non-smoker, non-alcoholic, no other history of any substance abuse, and no high-risk behavior. Family history: he is 4th by birth order and has 2 elder brothers and 1 sister. All are doing well. No history of sudden cardiac death in family, no history of any cardiac illness in the family, and no history of similar illness in the family. His socioeconomic status is he lives in a pakka house, belongs to upper middle class as per modified Kupuswamy socioeconomic scale. Treatment history: since admission to the hospital, he received some IV and oral medications, and his symptoms has improved. He is comfortable in lying down and walking till washroom presently. Coming to the summary, he is a 30-year-old male with a sudden onset severe retrosternal chest pain 1.5 months back, which associated with sudden onset rapidly progressive dyspnea on exertion, which was NYHA class 4 to begin with, and had a transient improvement, followed by which worsening of the dyspnea to NYHA class 4 again over a period of 1.5 months since, and he is in NYHA class 4 since past 10 days, with the associated history of palpitations on exertion since last 1 month. So coming to the possible, yes, sir.
Go back.
Yes, sir.
So how do you hemodynamically or conceptually, how do you explain what is happening? Can you tell me?
Yes, sir. Sir, basically, there is an episode of severe retrostral chest pain after which he has a symptoms
Yes,
of
retrosternal. I agree. No, history I understand. So retrosternal chest pain. What? It is ischemia. It is. What is? What do you think about it?
Yes, sir. Likely ischemic chest pain, sir. Yes, sir. He had an episode of chest pain, probably.
And then after the chest pain, these symptoms which are there.
Symptoms of volume overload, sir. Dyspnea and palpitations.
Volume overload.
Yes, sir.
What is in your mind?
Sudden onset of acute volume overload, sir.
Ischemic chest pain or chest pain followed by sudden volume overload. What is in your mind?
Sir, most the common differential for this is acute coronary syndrome. With it may be a large extensive anterior wall MI with acute LV dysfunction causing this LV dyspnea and as well as
where is the volume overload?
Sir, LV volume overload, sir.
Due to?
Sir, it may be because of ACS leading to acute MR, sir. Transient MR that has caused the sudden onset of orthopnea.
Transient MR.
Yes, sir.
So you say this acute MI complicated, acute myocardial infarction complicated by acute MR. That is your thought process.
Yes, sir. First differential is this, sir. However, because of the chest pain which lasted for an hour, and after that it is pin-pricking types only, with the significant history of dyspnea and palpitation, it can be aortic dissection with the acute aortic regurgitation. Another possibility it may be, however, there is no history of fever, which is very unlikely. However, it can be there in case of infective endocarditis, and because of that endocarditis, there is a perforation of the cusp that can also lead to valvular regurgitation. Another possibility is a ruptured sinus of Valsalva, which presents with this chest pain and palpitation dyspnea with a short history, and very unlikely, but it can be there as patient is a 30-year-old male without any history of hospitalization or immobilization or any limb swelling. However, because of any hypercoagulable state, there can be an episode of acute pulmonary embolism causing chest pain as well as the DR, so volume overload in the.
You said the age of the patient is 30, no?
Yes, 30 years, male.
30-year-old without any risk factors. Why did you put acute myocardial infarction as the first possibility?
Yeah.
And because the young coronary artery disease is very prevalent, sir, nowadays. Sir.
You have data to show that young coronary artery disease is there and increasing in India. What data?
Sir, in the inter-heart study, they have mentioned that.
Which study? Which study?
So the inter-heart study, sir.
Inter-heart study. Okay.
Yes, sir. They have mentioned that in the Asian populations, Asians and African populations, the young CAD less than 50 years of age, the prevalence is nearly 12 to 16%, sir.
What percentage?
12 to 16%, sir.
Less than 50 years. Inter-heart study. Inter-heart study.
Yes, sir.
Okay. You may be right. I don't know. So 30-year-old, but I would put the possibility as very, very low. 30-year-old without any risk factors developing is it following an acute, strenuous exercise?
Sir, he routinely do the activity in the farm.
This particular episode, was it associated with an acute severe strain?
Yes, sir. He was doing strenuous activities.
So then what is the possibility then? Rather than atherosclerotic coronary artery disease, what is the possibility? I agree ischemia and acute MI. What is the possibility?
It can be a aneurysmal sinus of Valsalva, which because of the physical.
No, ischemia only. Related to coronary, what can it be? Can it be coronary artery dissection?
Coronary artery dissection, yes, sir.
Yeah, okay.
Yes, sir.
And why can't it be acute MR and some papillary muscle, what is it, caudal rupture, and why can't it be an MR, acute MR? In age, he may be having previously existing mitral valve prolapse. Why can't it be an acute MR with a caudal rupture?
Sir, because of ischemia, sir, acute MR, sir. He had no history of, sir, any chest pain.
These are all mitral valve prolapse, need not have much history. No, he must have some
Yes,
chest
sir.
pain or something like that. Is it a possibility?
Yes, sir, it can be a possibility, sir. But because he had a transient improvement in his symptom after after an hour of the episode, and then again progressed gradually from NYK class 2 to 4 over a course of 1 month. So this.
So which among the things can have an acute improvement? You said acute myocardial infarction with MR, acute aortic dissection with AR. So why does all these three possibilities that you have put can have a transient improvement? Because you said that is one possibility against mitral valve prolapse and caudal rupture. Why should these three things have an improvement in between?
Sir, in case of acute MI, sir, as the pain settled and the patient had an transient MR and then he developed LV dysfunction. After a few days, he stabilized, and then he is now having a history of CAD with the LV dysfunction and gradually progressing dyspnea and palpitations. In case of, sir, acute aortic dissection, he might have a intimal tear at the ascending aorta that extended to the aortic cusp and caused the AR. And in a day,
why should he improve? Why should he improve?
Sir is asking, why should they improve? All the three conditions you are enumerating, 1, 2, 3, why they will improve? What is your point?
You said they have a significant improvement. Why should they improve?
Sir, basically, sir, he after that episode, he with what he routinely used to do, go to the farm and do his activity. He stopped himself from all those activities and preferred to stay at home only because of this episode. So it may be possible that he might feel all the symptoms. However, because he restricted himself a lot as compared to what he used to do previously, so he felt it better.
That is say applicable with MVP with MR also, no? With caudal rupture.
But sir, acute MR of such an extent will.
You said this acute MI with MR also will have the same. Okay, go forward.
I think go forward, yes.
So coming to the general physical examination, patient is conscious, cooperative, well oriented to time, place, and person, alert and responsive. Pulse rate 90 per minute, regular, high volume, water hammer in character, with no radiofemoral delay, condition of vessel wall normal, and all peripheral pulses were palpable. Blood pressure in right arm, it was 130 by 40, in left arm 128 by 42, in right lower limb it is 150 systolic, and in left lower limb it is 154 systolic, with a wide pulse pressure of 90 is there, sir. Respiratory rate 20 per minute, abdominal thoracic, regular, without use of any accessory muscles. His saturation is 98% on room air in all the digits. JVP 5 centimeter above the sternal angle with a prominent A wave. No pallor, icterus, cyanosis, clubbing, pedal edema or lymphadenopathy. Height is 160 centimeter, weight 50 kg, BMI of 19.5 kg per meter square, which is normal. Upper segment to lower segment ratio normal. His arm span 150 centimeters, so arm span to height ratio is also normal. He is afebrile. He also has peripheral signs of wide pulse pressure, Corrigan sign, Quincke sign, Dorizin murmur, and pistol shot femoral.
How
Skin,
much is this? What is this RA pressure?
sir,
Can you tell me RA
yes,
pressure?
sir, GVP is 5 centimeters above the sternal angle. So RA pressure will be 10 centimeter of water
Okay.
or 7 mm of Hg, sir. 7.3 mm of Hg.
Okay.
Skin, skull, spine normal. No marfanoid habitus. No signs of infective endocarditis. Fundus examination has no Roth spots and no other abnormality. On cardiovascular examination, sir, in inspection, chest was bilaterally symmetrical. Apical impulse is seen one space below the nipple, lateral to mid-clavicular line. No other visible arterial pulsation, veins, scars, or sinuses. On palpation, findings of inspections confirmed with the apex beat in 5th intercostal space, just lateral to mid-clavicular line with medial retraction. Hyperdynamic in character, LV type. Palpable systolic thrill is present in left 5th, 6th intercostal space, grade 2 left parasternal pulsation and palpable P2. On percussion, left heart border corresponds to apex, right heart border is retrosternal, liver dullness in right 5th intercostal space, gastric tympani in the left side and second right intercostal space is resonant. On auscultation, sounds S1 is normal, S2 loud P2 with the normal splitting. LV S3 was present. In murmurs, there was a harsh, high-pitched, continuous murmur, grade 4/6 with systolic augmentation, best heard in left sternal border in 4th, 5th intercostal space, radiating to right parasternal border, best heard with diaphragm of stethoscope. Another, a low to medium-pitched rumbling with diastolic murmur, heard at apex, with the bell of stethoscope at the end of expiration. Other systems, respiratory system, bilateral vesicular breath sounds with no added sounds. Per abdomen was soft without any hepatosplenomegaly. The liver span was 11 centimeter and CNS was normal, sir. So coming to this, sir.
Summarize the findings. Summarize the
Just
findings.
describe. Just read the murmur again. The murmur. Can I?
Yes, sir.
Yeah.
So, once a harsh, high-pitched, continuous murmur of a grade 4/6 with systolic augmentation, best heard in left sternal border in 4th, 5th intercostal space, radiating to right parasternal border, best heard with diaphragm of a stethoscope. And another low to medium pitched rumbling mid diastolic murmur heard at apex with the bell of the stethoscope at the end of expiration.
Okay.
So
What
this
is the diagnosis?
somebody said he is a 30-year-old male, farmer by occupation with a significant history of sudden onset severe retrosternal chest pain of 1.5 before 1.5 months, with the history of dyspnea on exertion, which was NYHA class 4 to begin with, and after a week progressed from NYHA class 2 to class 4 over a course of 1 month, and a history of palpitations on exertion and NYHA class 2 with a pulse of 90 per minute with a wide pulse pressure and the elevated GVP with the peripheral signs of wide pulse pressure, along with LV type of hyperdynamic apex in the 5th intercostal space with a continuous harsh high-pitched continuous murmur of grade 4/6 with the systolic augmentation in the left 4th, 5th intercostal space with the radiation to the right parasternal border and a low-pitched MDM at the apex.
What is the diagnosis?
So, sir, it is probably, sir, a ruptured sinus of Valsalva to the right atrium with a severe PVH, moderate pH, in sinus rhythm, in heart failure, presently in NYHA functional class 2 with no evidence of infective endocarditis.
Now you describe the murmur in left 4th and 5th space, right?
Yes, sir.
No, so there is no murmur in the 3rd space or 2nd space?
So it was best in left 4th, 5th, sir. However, it was there from
that, but then you have to say it is heard along the left parasternal border, maximum in 4th, 5th space or whatever.
Ji, sir.
No, because your description said only 4th, 5th space. So that looks as if it is not there in the 3rd space, which is very unlikely. You see,
Sorry.
in the diagnosis that you have made, the murmur, where is it originating from? It is originating from the
aortic root, just above the
aortic.
aortic, from
So it
the
is
side.
originating from the aorta. There is a leak
Yes.
from the aorta. So what
Yes.
level is the aorta? What is the surface marking of aorta on the
In the
chest?
left third intercostal space at the AIIMS area.
Yes.
Okay.
So it has to be there on the third space. It cannot be not there.
Yes, sir, it was there, sir. Yes, sir.
Okay, you said this diagnosis RSOV to RA. You have severe PVH, and what is the reason for the PVH?
And because of the his complaint of orthopnea, sir, significant complaint of orthopnea.
No.
He's complaining of orthopnea and all is okay, but what is the physiological or pathological basis for the severe PVH?
Why should PVH occur? That's what he's asking.
Because of the large amount of shunt from the aorta to right atrium to right ventricle into the pulmonary circulation, into an unaccustomed pulmonary circulation, sir. He had.
I am asking about PVH. Then all ASDs should have PVH. Large ASD should have PVH.
So it is causing LV volume overload because the LV is of normal size and now it is receiving a large amount of blood, sir, as compared to what he is supposed to receive, sir. So there is a elevation in LV and diastolic pressure also, which causes this.
So the volume overload in rupture sinus is of which chambers?
All, if it is in RA, it is a, sir, distal to the shunts are in all chambers. So as in our case, it is in RA, so RA, RV, LA, and LV, sir, all four chambers, sir.
Okay.
So what is
Why would, sorry, go. Why can't it be RSOV to RV? Why did you say RA?
Sir, because
Can it be to RV?
sir, one point is that it is because the radiation of the murmur is to the right parasternal area, sir. Second is because of the systolic augmentation, the continuous murmur was more prominent in the systole, yes, sir. These 2 points I would.
what type of shunt is?
Any other point which favors RV favors RA compared to RV?
Sir, the elevated JVP, sir, however, it can be there with RV also.
So JVP will be certainly high in RA. It will
Yes.
be definitely high in RA. Yeah, Dr. Hrishikesh, you were saying something. Sorry.
Now, what type of shunt is the RSOV to RA? What is that? Is there any?
Left to right, sir. High pressure to low pressure, sir. Sir, actually, what do you want to ask, sir?
No, what type of what is obligatory shunt?
Sir, obligate, sir, it is a continuous in the systole as well as in the diastole.
No, obligatory. What is the obligatory shunt?
So obligatory shunt. What is obligatory shunt?
Do you know what is obligatory shunt?
No, sir.
Oh,
No, that's very important. You must know that.
Obligatory shunt is the one which is independent of the pulmonary vascular resistance. So like LV to RA shunt, it will happen even if irrespective of the pulmonary vascular resistance. Okay. Okay. So what is the next?
So just a sec. So now it is RSOV to RA according to you.
Yes.
So what do you expect in the ECG?
Sir, in RS, in case of sir, RSOV, there is
what is the other differential diagnosis? You think this is the only diagnosis? This patient cannot have a differential diagnosis?
Sir, because of the continuous murmur, sir, in a.
So continuous murmur. So there are lots of causes for continuous murmur. What could be the other causes? You see, I understand the history is short and there is some history of chest pain.
Yes.
So we are used relating it to acute rupture. Is that correct?
Yes, sir.
So, but rupture could be chronic also. And what could be the differential diagnosis? What could be the other diagnosis? Can you tell us what are the other causes for this? For a continuous murmur like this?
Yes, sir. Sir,
So basically the continuous murmurs we group basically into the three physiologies. Either it is from the high pressure region to the low pressure region. In high pressure to low pressure, it can be either from the aorta to the pulmonary circulation, which we see usually classically in the PDA or AP window, or when there is a surgically created shunt, sir. Or it could be from the aorta draining into the right heart, which is the RSOV, or it could be the coronaries which are draining into the right heart, or the RA-RV, or it could be in the LA. So that could cause a continuous murmur, or it could be other shunts like in Lutembacher's with restrictive ASD. We can have a continuous murmur. Others would be, sir, there could be increased because of the increased flow, which could be because of the venous hum, or it could be hepatoma, or it could be Paget's disease, which would cause a, or a memory souffle, which could cause
Okay. So, okay, let's go to the ECG. What would you expect on the ECG?
sir, we will expect LV volume overload type of.
And
Along with that, in RSOV, there is a left axis or PR prolongation where it can have AV blocks or complete heart block if the aneurysm extend to the interventricular septum. And signs of RA and LA enlargement can also be there.
do you expect LVH or biventricular hypertrophy?
Both, sir.
What do you mean?
Sir, RV is biventricular enlargement, sir.
Biventricular.
Both ventricle can enlarge.
Yeah.
Yes, sir.
Okay. What does it show?
Sir, it is a ECG with the normal standardization and calibration in having normal sinus rhythm, and then axis of -50° with sir a small with a QR pattern in V1 suggestive of right atrial enlargement, and although it is not showing any sign of LV volume overload, sir.
So why you are not getting the sign of LV volume load?
Sir, because of just 1.5 months of this shunt, sir. So it will take some time, sir.
X-ray?
Coming to the axis, sir, chest X-ray PA view showing a fundus shadow on the left, trachea central. There is a cardiothoracic ratio of 55%, and there is an increase in the pulmonary vascularity in the upper and middle lobe of the lung, more on the left side, with a prominent.
What do you mean by increase only in upper and middle lobe? What do you mean?
The syphilization of the pulmonary vein, sir.
I see. Okay.
Yes, sir. With the sir, slight prominence of the right descending pulmonary artery.
No, so is there increased pulmonary blood flow or not?
Yes, sir. There is. Yes, sir.
No,
What is your evidence of, you said PVH, what is your,
Sir, the prominence in the pulmonary vessels in the upper.
no, that is PVH, that is PVH. What is the evidence of increased pulmonary blood flow? Is there any evidence of increased pulmonary blood flow?
And the perihilar.
how do you diagnose increased pulmonary blood flow?
Do you have endowed vessels? Do you have dilated pulmonary arteries? Do you have cardiomegaly?
And the prominent right descending pulmonary artery is 17 mm. And sir, end on vessel. And the pulmonary vessel till the periphery.
With this X-ray, what shunt do you expect?
यादव जी चलेगा लगता है कहाँ
More than 2 to
Hello. Okay, go to the echo.
Sir, in this parasternal long axis view, we can see LA, LV, mitral valve, aorta, and RV with the normal LV function and normal aortic and mitral leaflets. In the color Doppler, across the mitral valve, there is no MR, sir. And in the color Doppler at the aortic valve, there is mild AR, sir. In this parasternal short axis view, we can see LA, RA, tricuspid valve, RVOT, and the aorta and all its three cusps, and there is a defect in the non-coronary sinus with the windsock appearance and windsock appearance from non-coronary sinus to the RA, just above the tricuspid septal leaflet, sir. In this color Doppler at the parasternal short axis view, we can see, sir, color flow from the non-coronary sinus of the aorta to the right atrium just above the tricuspid valve, sir. In this color compare image in the apical fourth chamber view, sir, we can see color flow turbulence from the aorta to the RA just above the tricuspid valve, sir. And there is no associated VAC, and it was also not there in the short axis view also. In this apical 5 chamber view, sir, we can see the color flow across the aorta to the RA, sir, just near to tricuspid leaflet, along with no significant AR, sir, and no PSD also, sir, in this view. Sir, after this, the patient was taken for angiogram, and this is a angiogram taken with the pigtail catheter in the aortic root. The catheter course is from the femoral artery to the descending thoracic aorta to the arch and ascending aorta into the aortic root. And in this RO view, the shoot was taken, which is showing filling of aorta, and along with that, the flow of contrast from the aortic root to the right atrium.
Which sinus? Which sinus?
Sir, the catheter is in the right coronary sinus, sir.
No, is the catheter is the same sinus which is leaking?
No,
it's
sir.
a different sinus.
It is in right sinus, sir. The leak is from non-coronary sinus.
From this view, you can very well say it is in a right coronary sinus.
How do you say?
LAO view would be better.
You have another view with the same position of the catheter.
Yes, sir. It's the right one, sir.
Yeah.
Sir, in this LAO view, on giving aortogram, sir, we can see a flow from the aorta down into the RA, sir, with a non-selective filling of coronaries also, sir. Both the coronaries.
Okay, forward. So what will you do?
Sir, so the diagnosis of RSOV to RA is there, sir. So the mainstay of treatment for this is surgery for surgical closure. However, a feasible alternative is percutaneous intervention, sir. With
why do you want surgery if you can close it by device?
Yes, sir. We can, sir. There are few conditions where we can.
No, in this case, no, there are few conditions. What about this case?
In this case, we will do device closure, sir.
Why?
Sir, because there is no other complication like VHD or AR and the coronary ostia are also far away from the aneurysmal site. And so,
Okay, what route will you go?
sir, we
And
will
what device will you use?
Sir, we will go from we will pass a multi-purpose catheter from the femoral artery to the descending to the ascending and then to the ascending aorta, and a thermo wire will go from that multi-purpose to into the through the sinus into the right atrium, and we will keep it in SVC. And from the femoral vein, we will pass a snare, and the arteriovenous looping we form. And then from that arteriovenous looping, we will be in the direct communication from the femoral vein to the aorta, sir, in the ascending aorta. And over that, we will pass a delivery sheath. And from the delivery sheath, we can deliver a Amplatzer duct occluder device, sir.
Which ADO?
How
ADO
will you
2,
measure
ADO
the
1,
size of the defect? What is
ADO, yes, sir.
the size of the defect? How will you measure? What is a correct approach?
Sir, fluoroscopy, sir, we can see, sir.
No.
You have already done the angiogram. Now, where will you measure? How will you size the defect?
The size of defect will be decided by the aortic end of the sinus, sir. And the larger part of the disc size will be kept towards the aorta, sir.
Will the practice of doing a CT angio prior to angiogram is being practiced by practically all the cardiologists, which can give an exact anatomy, the size of the defect, how much away it is from the coronary?
Sir, sir, in case of confusion, sir, we can go for CT.
So you will do CT later on, or you will do CT angiogram before your diagnostic angiogram? It will save a lot of other things if you have
Yes,
a
sir, yes, sir. Prior to going for a catheter intervention, sir.
Which device you will prefer?
Sir, Amplatzer duct occluder, sir, ADO.
The ADO 1 or 2? There are different ADOs. No?
One, sir.